all of the best information out there and bring it to you live. We're going to be talking about rescue ICSI and whether that is actually helpful or not. And it's a pretty brief topic, so we're going to leave lots of time for questions tonight, so you can start asking your questions at any point in time if you have them. Looking forward to sharing answers with you guys, and hopefully we'll draw a big crowd tonight, because I think this is an important topic, as it seems to be occurring more and more all the time. And we had never done it before, so I was quite curious to see whether or not this is something we should be exploring. So we're going to review the ins and outs of that. We'll give everybody the traditional time to get on board, and wish you all a hopefully very happy and enjoyable long weekend. I'm assuming some of you that already have children have your kids going back to school. I have adult children, and my adult children seem to be finding out that all their classes are online. So we're thinking they're going to be coming back home pretty soon. For those of you with young kids, I think this is going to be an interesting time as schools reopen and we see what happens with the virus. So it should be a very dynamic and interesting opportunity for all of us to navigate through. Please stay safe. Make sure that you're doing everything you can to keep yourselves and anybody that you know out of harm's way. So still lots of hand sanitizing, wear your masks, don't go anywhere without a mask. And it looks like there's some pretty promising results coming through with many of the vaccines. So hopefully by late fall, maybe early winter, we'll start vaccinating people and go from there. I read a very interesting statement in some of our hospital information that indicated that Canada had offered to buy 190 million doses of vaccine when we really only need 37.5 million. So they may have kind of overstretched themselves a little bit there, but we'll see how things go. And I guess it's better to have tons of protection than not to. So hi to everybody that's joining us. I'm getting lots of hellos, so nice to have you all on board. And if you have any topics you want us to discuss now or later, don't hesitate. Make sure you know that you're signing on and leaving us info on what you'd like us to review. So I have to kind of go through these topics and find things every week, but if somebody has a topic they want us to do, we're more than happy to review those, and we'll go over them, and then that way we have topics that are pertinent to what you're looking for and answers that you want. I did have a recent request from one of our frequent viewers to go over what supplements work. We've done that a number of times. So we just looked at natural treatments for PCOS, natural treatments for endometriosis. We've done vitamin D in the past, and I've got posts on that. We've looked at Mediterranean diet, melatonin, some HCG therapy. So there are a number of our fertility factor fictions. So go to our YouTube channel, www.youtube.com/Dr. Victory, and you'll find tons of information there from all of our previous posts. So we'd be happy to share those with you. And as always, like, comment, share. We want to make sure we know how we can improve this for you guys. So if there's things you think we can do better, by all means, let us know, you know, how we can improve the experience for you and make the information better. Okay, so we're going to get started. And tonight's topic is rescue intracytoplasmic sperm injection. And it's from a systematic review. Now, admittedly, this review is a little bit older, and that's because there hasn't actually been a lot of new data on this, but I did review some of the new data, and I'll share that with you as we go through this. So let's go through all the basics here, right? So IVF is the process of IVF, and that's where we're making you make lots of eggs usually. We take the eggs out of the ovary with a needle, and then we go ahead and get the eggs fertilized with one of two techniques. Conventional IVF is where you take the sperm, pour it into the dish with the egg, and hope that one of the sperm is going to fertilize the egg. ICSI was a process that was developed where you can cherry pick individual sperm and then inject them into the egg to kind of force the fertilization. So this is a very useful technique for sperm that don't swim very well, for sperm that are very weak, and possibly for couples where they have lots of fertilization failure. Of course, it depends on whether the fertilization failure is because of the male or the female, but it does help in many cases. And there's no question that in the hands of a true expert, the success rate can be much, much higher in terms of fertilization when you use ICSI rather than when you're using just conventional IVF, because conventional IVF has typically a 50-60% fertilization rate, whereas in good hands with ICSI, you can get as high as 90 to 100% fertilization rate. So, that's kind of a very significant difference, because if you have 10 eggs, you may be getting 5 or 6 embryos with conventional IVF. But if you're doing ICSI, you may get 9 or 10 embryos. And now you've got many more that have an opportunity to make it to blastocyst. It's not all without some, sort of elevated risk. ICSI has been proven to, number one, increase congenital abnormalities. So normally the baseline rate is about 2 to 3% in the whole population. And when you use ICSI, it's going as high as 4 to 5%. The other problem that we've encountered or seen is that if you have male factor infertility and you do ICSI, there's a reasonable chance you're passing that on to your male offspring. So there are some glitches with doing ICSI, but the fertilization tends to be very valuable. A lot of the societies are now saying don't necessarily do it if there isn't male factor. I'm not sure I agree with that statement, because you really are compromising your success to some extent when you're not getting as many embryos out of the package. And that can have financial burdens for people. Now, if it's all insured, that's a different story. But if insurance is not part of your plan, or you don't have insurance because of where you live or your financial resources, then you really need to think about the extra value you're getting from having all of your eggs or most of your eggs fertilized compared to not all. And it is very dependent on where you have it done, because some centers have lower success rates with ICSI than others. And so if your center's only getting 60 to 70% with ICSI, then you really want to make sure that you're going to a better center where they can achieve a higher success rate. So looking at rescue ICSI is very interesting. So when we do ICSI, typically we take the egg, we strip the cumulus cells off of the egg. That's kind of an outer coating of cells that surround the egg. And then some embryologists will go ahead and inject the egg very quickly. Some will wait a few hours for the egg to settle, and then they'll inject the egg with the sperm when they're doing the ICSI. You have to kind of hold the egg with a very minimal amount of suction on a tiny, tiny little glass pipette. And then you take the sperm individually, you load it into the needle tip, and then you inject that into each egg, hoping to generate the fertilization. And some people can do this very efficiently, very quickly. Other people a little bit slower. But again, if you have a good program with a good embryologist, you'll get very high success rates. So rescue ICSI is when you've done conventional IVF. So you have not used ICSI, you've not injected the sperm, you just drop the sperm in the dish and kind of put your hands up in prayer mode and hope that it's going to fertilize, and find out that later at some preordained time, it has not worked, and you now have to go back and try and fertilize it. So initially, people always did the first look of the embryos the day after. So let's say you have your egg retrieval at a reasonable time in the morning, right? 8 o'clock, 9 o'clock, 10 o'clock, something like that. So the next day, your embryologist will go and look at your embryos and say, hey, the embryo didn't fertilize, and at that point, they were saying, hey, maybe we have the chance to still inject the egg. And so they took the sperm and injected it directly into the egg, because the egg is still unfertilized, so maybe you can still force it to become fertilized via ICSI. Then people started moving that time up a little bit to somewhere between the 4 to 6 hour mark, or sort of 6 to 8 hour mark, and 8 to 12 hour mark as well. And there are some studies that have looked at the differences in outcomes between those different times. So rescue ICSI is that process of saying, oh my God, my egg didn't fertilize, I need to force the fertilization by going to intracytoplasmic sperm injection. So this review is quite interesting, because these guys started out with a literature search, as usual, and they found 65 articles, but they narrowed it down to 25 based on their criteria. They found an additional 13 articles, so that came out to 38. When they looked at the actual articles, they got back down to 25, and 13 of them had just abstracts, not the full text. So they then go through the data, and I want to share some of the data with you. So I am going to go to our sharing thing, which is this one here, I think. Yep. Yeah, application window, and there we go, share. Okay, so hopefully you guys can all see that. I'm going to blow that up a little bit for you. So this is the article. You can see it right there, Rescue Intracytoplasmic Sperm Injection, a Systematic Review. So I'm going to go right up to the data because that's what I want you to look at. So the first grouping of studies included studies that had what's called TFF. So that is total fertilization failure, which essentially meant none of the eggs fertilized. They showed up in the morning and they found out that there was no fertilization. So that's obviously a huge problem, because if you have total fertilization failure, you're now dealing with the fact that your patients have nothing. And so they are going ahead and doing rescue ICSI on those. And this started back as far as 1995 was their earliest study there. And then they have another grouping of studies, quite a number of them, which had low fertilization rate, or what they called other, which was just another grouping of low fertilization. So in the grouping with total fertilization failure, if you look at the number of patients, they're all relatively small, 5, 24, 19, one of them's 54. However, as you get down lower and further on in years, there are one or two that have quite a number, including one that had 534 patients in it. Now, I'm definitely concerned about any center that had 534 complete fertilization failures, because we never had that. We always ended up with some fertilization. In fact, I don't think I can ever remember a couple that had total fertilization failure with us. So that's a very high number, probably something unusual going on in that program. But nevertheless, that's the data that they presented. So again, it's really important you know what your center's protocols are, you know what your center's results are, and it's completely fair to ask them, what do you guys do? When do you check for your fertilization? How long do you wait? So all of that can be really, really important to find out. When they looked at the other studies, again, very, very small numbers. The highest number is 82 for the group where they had low fertilization. So most of these studies were retrospective. Some of them were prospective. I think just 2 were prospective or 3 were prospective. So retrospective studies are when you look backwards in time to see the data that you have from what had already been done. You can't really control for anything. You can't really keep your eye on what exactly is going on. Whereas with the prospective studies, you can kind of follow people forward, so you can establish the criteria you're looking for at the beginning and then check those boxes off as you go through. Okay, so where did this all leave us? Well, here's the nitty-gritty of these studies. So if you look over here where it says pregnancies and number of embryos transferred, you can see, or even number of fresh embryos transferred, you can see that by and large, the outcomes are abysmal. So why is this important? Well, more and more I've been hearing that there are several programs, including one big one in Toronto, that is turning to rescue ICSI, and not only turning to it, but actually charging patients extra to do this if they find out that there is total fertilization failure, which seems kind of absurd in my mind. Why would you not just ICSI people at the beginning, or if you have a suspicion it's not going to work? Obviously, if you're caught off guard, the patients didn't want the ICSI, that's a different scenario. But apparently this is becoming a growing sort of commonplace thing, and this should definitely not be commonplace in any center. So most of these programs, they had 0 pregnancies. You have very low pregnancy rates in the other. So out of 48 embryo transfers, which included 140 embryos, you had only 8 pregnancies, so abysmal results. You're not getting anything really improved. They're all single digits until you get up to one study, which I'm trying to get to right here, where they showed a little bit of an improvement. And you'll see that those improvements come way over here in the right, or in the screen left-hand column, which shows that if they checked after 8 to 9 hours or 9 to 12 hours, now you're getting 54 embryo transfers, 27 pregnancies, 55 embryo transfers, 25 pregnancies. So if the time interval was shorter, the results were better. Same thing here. This study by Zhu et al. Had 7 to 12 hours, and they had 30 pregnancies out of 69 embryo transfers, whereas in the same study, if they did the rescue ICSI at 23 to 26 hours, out of 12 embryo transfers, 0 became pregnant. So as you dial through this, you can see more and more for the programs that did it very quickly, they had good success rates, or at least reasonable success rates. And for the programs that did it slowly, they had abysmal success rates. When I looked through this for newer studies to find out what some of the newer studies were doing, it was the exact same thing. So people are essentially finding that even in the newer studies, if they had short time intervals, then they had good results. So if you look down here again, 8 to 10 hours, you're getting 36 pregnancies from 70 embryo transfers. Again, that's 146 embryos, so a low rate overall, but better than nothing. And in the day study, when they waited just somewhere over 6 hours, they had very large numbers of embryos, 149 embryos transferred, 75 embryo transfers, 26 pregnancies. So again, a little bit lower than we'd ideally like, but still reasonable for people to consider. So is it a fact or fiction that rescue ICSI works? It is a fact that it works, but at the same time, you got to be very cautious because the likelihood is very, very high that it's not going to work if they wait. Why is this a problem? Well, if your egg retrieval is later in the day, let's say you got your egg retrieval even at noon or 10 o'clock in the morning, 11 o'clock in the morning. So there are no embryologists I know of that are going to go back and check the embryos at 6 or 7 p.m. in the evening. Most of them have gone home by that time. And that would be the rough time that those embryos would be at that 6-hour mark or the 12-hour mark or 8-hour mark, whatever you're going to use. But ideally, based on these newer studies, somewhere around 6 to 8 hours to check to see if they fertilized or not. Because again, if they've left the embryos in there for, the eggs in there for 2 or 3 hours before they fertilize them, then you're now looking at, okay, I had my egg retrieval at 11. They didn't inject or at least fertilize them till 2, let's say. So now 6 hours later, it's 8 o'clock at night. I'm not even sure I want my embryologist coming back at 8 o'clock at night because they're going to be exhausted the next day, and that might compromise things for whoever's coming later. So unless you have tag teams of embryologists who can come and check the embryos at different times, that kind of program just simply does not exist in very many places, or any for that matter. So rescue ICSI is traditionally going to occur the next day. And with those next day results, the results are abysmal. You're almost better off telling them not to go ahead and do it and save your money and then talk to them about why they didn't do ICSI to begin with. And that's a much more valid approach to things than getting 0% success rates on something that just simply isn't going to work, and they're now charging you extra for when it isn't your fault. So should you consider ICSI? Yes, if you're going to a good program, you should consider ICSI, but remember, it does have disadvantages as well. Should you consider rescue ICSI? No. If it's being done the next day, rescue ICSI has terrible results that are very, very poor. At the end of this article, they say, yes, it can be done and you will see some successes, and I showed you that, but the success rates are very, very low for the number of embryos that are being transferred. And so I'm not sure that that's really a valid approach to things. It makes a lot more sense to figure out why the embryos didn't fertilize, deal with that, and then move forward. And just yesterday, in Fertility and Sterility, the scientific journal, they published a scientific article demonstrating that they now have a technique where they can try at least to determine if fertilization failure is coming from the male side or the female side. I haven't read the article yet, but I showed it to my embryologist, our lab director, Dr. Khosravi, and she says that it is very possible, but requires a hell of a lot of very sophisticated research lab-based equipment. So I'm not sure it's going to be mainstream anytime soon, but maybe someone will find a way to make it mainstream for us so that even the small centers can use it. And that would definitely be absolutely awesome for all of us, because it'd be very helpful for us to be able to tell you guys, that it's the male side of things or the female side of things that's causing the fertilization failure. So once again, is it a fact or a fiction? If it's a late rescue ICSI, it is a fiction. It's likely not going to work. If it's an early rescue ICSI, somewhere around 4 to 8 hours or 4 to 6 hours, there's a reasonable chance you'll get success. And the newest article, which was 2018, was a randomized controlled trial, and they did show that the success rates were actually pretty reasonable, almost the same as what you'd get when you're doing just a normal ICSI at a normal time. So make sure you like, comment, and subscribe on our YouTube channel. That's where all our Fact or Fiction videos go to. They're also available for 24 hours on Instagram, and they're also available on our Facebook page. And if you have any questions, don't hesitate, ask us, and we will happily go over those issues with you and your concerns and questions and address them all. So thanks for joining us for that part of the program. We're going to go to questions now. And I don't know, do you have questions there, or do you want me to ask them from here? Okay. I think we've got a bunch, so let me go through those. And you guys can feel free to ask anything you like. I got a comment that says, vaccines from China don't record to do vaccines. Not sure what that means, but thank you for sharing that. Okay, first time doing IUIs, what someone needs to know to prep for it. Oh, that's a great question. So if you're doing intrauterine insemination for the first time, what you need to know for that is that there is a process involved. So step one is making sure that you make your eggs, or egg, if it's just one egg and it's being done natural. Step two is making sure you've got decent sperm. And step three, these days for us, is making sure we know your sperm DNA integrity or fragmentation, because there are different techniques that can be used to alter or prepare the sperm. And if you have high DNA fragmentation, we use a device called Zymo, Z-Y-M-O-T, which helps screen out a lot of the abnormal sperm or abnormally high DNA fragmentation sperm. Gets rid of 90% of them in one of their own internal studies, and that really can help improve the success rates. Are we actually seeing improved success rates? We really are. It's actually quite a significant improvement in success, and so a lot of our patients are now doing that. It is a little bit more expensive. We only charge $100 extra for it, but it does seem to significantly improve your success rates when you're doing the IUI. As far as the actual process of the IUI, you need to show up with the sperm sample or produce it in the center you're doing it at. Most centers have that available to you. And once you have the sperm sample there, it needs to be prepped. That normally will take roughly half an hour, sometimes a little bit more. Once it's prepared, different centers have different techniques. We clean the mucus off of your cervix because we don't want to be pushing the mucus into your uterus. We know that that is not ideal for implantation. So we spend a lot of time cleaning the mucus out. You then have a very soft catheter which floats, and I literally mean floats up into your uterus. Now, you'll remember from one of our previous episodes that the only predictive factors for IUI were the total count and whether or not there was pain at the time of the insemination. So we spend a lot of time making sure that your uterus is calm, you're very relaxed, that you're not having any pain during the procedure. If you are having cramping, we wait until the cramping is gone. Then we inject. That should be painless. I normally leave the catheter there for about a minute to be a natural blockade against some of the sperm wash coming back out, because it often does. And then you very gently pull out the catheter. There's no evidence that you need to hang around, but we do ask our patients to stay there. And we tilt the bed a little bit so that it's hopefully keeping the sperm inside. Leave them there for about 15 minutes, and then they can get up and walk away after that. Expect a little bit of dripping of fluid or lubricant from the speculum that went in. And then after that, you should be back to normal. We do encourage our patients to have sex again. Several reasons. Number one, it's never going to hurt. Number two, you have improved sperm DNA fragmentation in a second sample, especially if it's produced within 3 hours. And we've reviewed that on, I think, our Instagram posts before. And you're definitely increasing the total sperm count, which is going to be beneficial as well. So we encourage our patients to have intercourse again right after, if it's available to them. Obviously, you have to be a heterosexual couple. And then once all of that is done, we start our progesterone the next day. Make sure you're on your vitamins, and then kind of go through the 2-week wait. Don't do anything too exciting. Don't do anything too crazy. Just kind of mellow, be yourself. Try not to stress, which I know is hard for a lot of people to do, but that's the best thing. And that's pretty much all there is to it. The IUI process itself takes about 2 minutes. And that's including cleaning the cervix unless you've got really thick mucus. Okay, next question. Oops, sorry. Hi, Dr. Victory. I know that funding has run out in Windsor Sarnia for IUIs. Is it still possible to work with a TO clinic for your Windsor patients? If how does that work with blood work and ultrasounds? Hi. It is possible to work with a Toronto clinic. In fact, we found one and we're just finalizing the negotiations on the contract. So we will have access to some additional funding out of Toronto. The problem is when you go to Toronto, the cost of the IUI is a lot more. So sperm wash in Toronto is about $500, whereas we're only $350 here. And we're only charging $600 if it's a natural cycle. Now, if you have to do shots, that's a different story because it's a lot more. But if you're just doing natural cycle where you're watching your ovulation surge on its own with just an ovulation predictor kit, we're only charging $600. So the drive and the time off work and all that stuff to go to Toronto literally is going to cost you more than just paying $600 to have it done here. But if you're doing it for injectables, yes, we're working that part out with Toronto. And we should have an answer for you hopefully by the end of this week, if not the week after. So we've got a team working on that right now, and we'll have a center to do that for you in shortly. So yeah, we're working on that. And we do work with some other Toronto centers that can accommodate that as well. I was wondering if you had any options on the keto diet, options or opinions, on the keto diet during pregnancy. Oh, I was doing keto and losing weight and just recently found out I'm pregnant. Hey, congratulations. I still have weight to lose. Do not try to lose weight while you are pregnant. You can hover, but don't try losing weight while you're pregnant. That's not a good idea. And I definitely would not be on a keto diet while you're pregnant. You want a healthy, balanced diet. You want to continue to exercise. Keep your calories low. You do not need to do keto to lose weight. You can do weight loss with a normal diet, just low in calories. So don't do keto while you're trying to while you are pregnant. Hey, Nat Crawford's with us. Hi, Nat. Saw an ad for InvoCell previous to your live. Opinions on InvoCell with IVF and InvoCell with endometriosis. So I'm not aware of any data specific to InvoCell with endometriosis, so I can't answer that. I can tell you that my knowledge of InvoCell is that the success rates are very low, usually around 20-25%. So why you would pay that much money, because it's still thousands of dollars, to incubate things in your vagina and then have them stuck inside you, which is not where anything normally incubates other than bacteria and yeast or viruses, makes absolutely just no sense to me whatsoever. And it's literally the success rates we're getting from doing insemination with shots, which is probably still cheaper than doing InvoCell. So I would not recommend InvoCell. It was presented to us. I'm not a believer. Maybe if they get data that shows it works a lot better, but not with the rates that they're getting right now and the literature that's available on it. Have you come across issues where the estrogen given in a medicated FET increases TSH levels? Yes. So there are some women whose hormonal therapy in preparation for a hormone medicated frozen embryo transfer cycle actually interferes with their thyroid function. Whether it's the estrogen or the progesterone or maybe even just the stress, I don't think anyone could ever tell you. But those are patients where we actually avoid using a lot of estrogen. I have one right now who's coming up for an embryo transfer soon, and we absolutely have to be incredibly careful because her thyroid goes crazy when we do her frozen embryo transfer prep. So she needs a lot of TLC, a lot of monitoring. So you could try natural. The estrogen component of your lining is less important than the progesterone component is. So make sure that you're monitoring your estrogen component to see, your progesterone component. You don't necessarily have to take estrogen in a cycle. You could do it natural. Okay, let's take some questions from the other side. I have PCOS and my AMH is 20. and my infertility doctor said, I don't ovulate and drugs and injections won't help me. What do you recommend? I recommend you get a new infertility doctor. So there is absolutely no question that if you have PCOS, that it will improve when you take pills. So, excuse me, letrozole has proven benefit. Clomiphene has proven benefit. Metformin with those two can help. There's good data on inositol, which is a natural supplement, NAC as well, which we've talked about on the show. So I don't know what your infertility doctor is talking about. That's absolute nonsense that the pills and shots won't work. They may be trying to push you into IVF. You don't need to be pushed into IVF. There's lots of options for you. In fact, if the only problem is PCOS, it's very rare that you actually need IVF. You can probably get away with just ovulation induction, which would be taking letrozole. If you go on our website, www.drvictory.com, go to the resources guide. We have a little flow chart of letrozole and what to do and how to take it. Get a prescription for letrozole. It's probably all you need. Hello, what are some other common causes of female infertility besides PCOS or endometriosis, especially as it relates to obesity? Thanks. Okay, so obesity in and of itself can be an independent predictor of infertility. Again, on our website, on that same resources tab at the bottom there, or no, actually on the top, there's a whole thing on the relationship between weight and fertility. And if you go to the bottom of that actual page, after you click on it, there's something that says download the long booklet. And it's a very extensive sort of explanation of how infertility and weight are related to one another. So aside from obesity and PCOS, insulin resistance can be a factor. Patients who have hormone problems can have issues. Certainly if your cortisol levels are elevated, your testosterone levels are elevated, those can affect things. There can be egg quality issues, safety of pregnancy, miscarriage, even aneuploidy can be increased when you have obesity as a risk factor. In terms of other factors, so chronic anovulation or oligoovulation, where you're not making or releasing your eggs, getting the sperm and the egg together. So whether there's an obstruction or if there is blockage in your tubes or in your cervix, or there's fibroids, polyps, and so on inside your uterus, or even adhesions inside your pelvis from previous infection. I've had women come in who have what I call functional obstruction, where the vagina is what we call patulous, so it's fairly thick, I guess is the best way to describe it. And so the cervix will actually seal against one of the floors or the ceiling, depending on the position of the cervix of the vagina, and it actually kind of functionally seals off. Nothing's getting through there because it's literally being blocked off by the vaginal walls themselves because there's a little too much tissue in there. So there are various different ways. We do know that egg quality is hampered by obesity itself, even if you don't have PCOS. And so that can definitely be a significant factor. So those are some of the things that can contribute. Is probiotics bad when trying to conceive? No, actually we use probiotics for our patients doing frozen embryo transfers. So I think it's great when you're trying to conceive. Long question. Hello, and sorry for this long question. Is there a blood test available to see if a woman has become Rh sensitized due to no RhoGAM shot given after previous pregnancy losses? If a woman is sensitized, is there anything that can be done to help the pregnancy along, especially early on, or is this a hopeless situation if the baby happens to be Rh positive? Is it possible that this could be a cause for miscarriages? Oh boy, that is a long question, Adriana. Okay, so yes, you can do a standard blood test with antibody screening. So it's called a blood group and type with antibody screen, and it'll tell you if you've been sensitized. Is it hopeless? No. So if your partner is positive and you are negative, keep in mind that only 15% of the time is the baby negative. 85% of the time it'll actually be positive. So it's not hopeless at all. And even if you are sensitized, there are treatments for it now. They're not necessarily gentle. They can include needing to transfuse the baby while it's still inside you. But this is rarely a cause of very severe complications these days. We just don't see it that often. So there are lots of options. Worst case scenario, yes, you would need a gestational carrier where that person is obviously not sensitized, and you would go through the IVF process put your embryos into somebody else. I've never had to do that for this situation. So you're probably in very good footing there. Can you talk about how to pick a good clinic? I failed twice, 2 different clinics. Not sure what to do now. Wow. So first of all, I'm very sorry for the 2 failures. For me, the things that are most important are knowledge, and then honesty, and then the skill. And I think the skill actually comes last, because the truth is that you actually need to have someone that knows what they're doing. And then you need to make sure that they're actually communicating it to you effectively and honestly, right? So if the driving force behind the practice is a dollar sign, you're never going to get the answers you want, and you're never going to get the treatment you want. If the driving force is helping people, which unfortunately seems to be somewhat rare, then you're going to get good care. So, I mean, I've given shout outs to people before. There are loads of people out there that really care about the patients. And some of them are watching the show right now. So, those people really care, and they're here to help you through this journey because they want to see you succeed. But there are lots of places out there that really, the dollar sign is the first priority. And unfortunately, that's not healthy for you or for them, quite frankly, or for anybody. So step 1 is find a place where the physician is knowledgeable. They're willing to communicate with you. They're willing to try and help you out. And then step 2 is find someone that obviously is going to be honest in conveying the information to you. Why did you fail? Was it male factor? Was it female factor? Is it their lab? Did they have a glitch that day? Did they use the wrong protocol for you? Or is it a problem with you? Is your egg quality hampered or the sperm quality hampered? And they need to be honest with those things about you. And then finally, of course, you need a good lab and a good doctor who knows what they're doing, especially when it's going sideways. So, for our practice, I cancel people when I know they're not going to succeed. I'm not going to let you go through an IVF cycle and hand over 10, 12, whatever $1,000 to end up with a cycle that's for sure not going to work. So if it's taking 14, 16 days to make your eggs, as we've reviewed on the show before, the success rates plummet. So I'm not going to let people do that. We're going to make sure we tell you early on, you are not doing well enough. We need to stop. Maybe we need to adjust our protocol. Maybe that wasn't the right one for you, or maybe this just isn't going to work for you because there's an egg quality problem, or again, a sperm quality problem, as the case may be. Honesty is important. Skill is really important as well. But the truth is, what you really need is just someone knowledgeable who's going to help you out. And I would literally go there with a checklist, kind of see a bunch of different physicians and say, these are the qualities I need. Did they check off those boxes, right? Were they honest? Did they know their stuff? You can ask them questions from our shows that take the information with you and say, what's the data on this? And if they don't know, those are people that are just, those are the cookie cutter medicine people. And like I always say, and I hate the fact that I love this phrase now, but, we're not baking cookies, we're making babies here. So cookie cutter medicine does not work in IVF. You have to know what you're doing individually for each patient, or else it won't work well. So hopefully that will help. And I know you reached out to me online. I'm happy to help you out any way that I can. I do know good people in most places, including Europe and Canada and the US. So if you can't get to us and you still want to see someone, let me know and I'll send you to people that will definitely take good care of you. These are people I look up to, so I wouldn't send you just to anyone. What are the injectables for IUI? So anytime we talk about injectables, we're either talking about FSH or LH products. So these are the natural hormones your pituitary gland produces to stimulate your ovaries, in particular FSH, or we are talking about injectable progesterone, which is used later in the cycle, not at the beginning. So if you are talking normally about injectables, you're actually talking about getting injectables for growing the eggs to get them ready to release so that you can then do the insemination with 2 or 3 eggs instead of just 1 hanging around. Thanks for explaining about ICSI. Whoops, sorry, I didn't want to do that. Hide that message. Okay. Hi, Dr. Vickery. What would you suggest to a woman who gave birth 15 months ago and now has noticed periods are different from before birth, meaning they are a bit heavier but shorter? Nothing. That's normal. Your uterus changes shape. Your weight may have changed. Your hormones may have changed. Age has a huge impact, so I wouldn't worry about that at all. If you think your periods are getting very close together or very far apart, you're having any perimenopausal type symptoms, hot flashes, night sweats, mood swings, vaginal dryness, decreased sex drive, sleep disturbance, make sure you go see your doctor to get your hormones checked. It could be something as simple as your thyroid, or God forbid, it could be something wrong with your ovaries. So make sure you get that checked out. Oh, I have a good question here. Hi there, what are your thoughts on Recavel versus Gonalef? Is Recavel better or safe? Okay, so there's no data whatsoever anywhere that any medication ever was better than any other medication ever. So at least for shots. In pills, letrozole for PCOS is definitely better than Clomid. But for shots, none of the meds have ever been proven to be better. However, every physician has their own likes. I will say that we've been playing a little bit with Recavel. I'm a diehard Gonalef and Menopur guy, so I don't represent one company. I routinely mix products from Serono and Ferring together and have very, very, very robust, excellent results from that protocol. But there are some people that seem to respond well to Recavel. The key with Recavel, which is the selling point of Recavel, is, and this might freak everybody out. So Gonalef is made, I think, in hamster cells or mouse cells. So they train those cells to actually produce the protein, the product, the hormone. And when you are using Recavel, it's actually made out of a human cell line. Why is that important? Because the way that little bits of sugar are added onto the hormone is called glycosylation, is different in an animal model compared to a human model. So it's probably a little bit more human when it's coming out of the human cell, and maybe that glycosylation has an impact on the success of the drug. So in my own experience, limited as it is, with Recavel, we've actually had very robust responses. So we are using it to play with in some of our patients that haven't done as well previously. So great question, but it doesn't matter what med you're on. Typically the med is not the deciding factor. Okay, what's the next question? Doing vaginal progesterone, if you can feel your cervix extremely low, is this an issue? Should I bring this up at my 12-week appointment? Oh, dear God, yes. If you can feel your cervix, you should bring it up at your 12-week appointment, unless you've had multiple previous babies or obesity is a big risk factor. So if you're a reasonable-sized lady and you've not had multiple children before, if your cervix is that low, somebody needs to make sure it's not getting short. So that's really important. Have that checked out. For sure, have that checked out. Is there anything we can do to improve our chances before and after transfer? So before, there are loads of things you can do. So watch your weight, have the Mediterranean diet, take melatonin, loads of vitamins, especially vitamin D or prenatal vitamin. Stay very, very calm. We use aspirin, so that helps as well. Make sure that all of the hallmarks are occurring for your endometrium. It's the right thickness. It's not too thick. It's not too thin. It's compacting after you start your progesterone, and that it's not contracting. So all of those things are important. What can you do after? Sex afterwards is actually being shown to improve the success rate. So I guess have sex. Stay calm. That's very, very important. For the love of whatever you hold dear and holy, stay off of Google. So the worst possible thing you can do is go online and start searching everything, because when you're there checking every single flinch and flutter and twitch that you have, it will drive you insane and you will not have good results because you're stressed, and stress reduces success by up to 60%. So make sure that you are staying calm, you're staying positive. Meditation, prayer, light yoga, that kind of thing is all really good. Eat healthy. Don't go on a sugar binge. Don't go on a cholesterol binge. Anything that kind of helps you stay calm, healthy, natural, those are all good features to help you with assisting you. What are your thoughts about embryo glue, HCG wash, and assisted hatching? That's the second part of that question. Wow, your computer just kind of shut and came back on, but it's still running. My thoughts are the following. Embryo glue has never been proven to work, so we do not use it. HCG wash we did review in a previous Fact or Fiction. That was a while back, so several months back. You can find that on our YouTube channel, so it does work. There's a good meta-analysis done which showed that HCG wash 15 minutes prior to embryo transfer improves success rates. So we do that for our patients that have had failures, and it's dirt cheap. In fact, I think we just did the last bunch free. But you just basically buy your HCG and just show up, and we're happy to help you out. And then assisted hatching is a protocol that a lot of places use. The data on this is not clear-cut. So there are studies that say it's beneficial, studies that say it's not. However, most centers do employ assisted hatching, and I'm a believer. Interestingly, different people hatch at different times. So some will hatch when the embryos are fresh, and some will hatch after they've thawed frozen embryos. So I know our current lab director believes in doing it after you've thawed frozen embryos, not when they're fresh. So it depends on what the situation is, and certainly if you're biopsying, you have to hatch. So we do it, but I need you guys to, look into those things independently as well. So you got to talk to your center, see what their skill level is, see how they're doing it, who's doing it, why it's being done, and so on. If you are doing an HCG wash, it's a very, very small amount, 500 units of HCG. And don't go testing your preg test right after, because it actually can show up in your urine, and it'll show up positive. So please don't come in 3 days later saying you're pregnant, because you actually may not be. It's a false positive. So make sure you get checked out. But embryo glue, waste of money, don't do it. If IUI is negative, do you have a follow-up appointment with you, meaning me, before next cycle, blood work to determine if positive, negative tomorrow? Okay, so hopefully positive vibes. So from everybody, send out some thumbs up to Kel. Hopefully that's going to work out just fine, and you're going to be pregnant. We won't need to worry about it. We do follow-up appointments whenever you want them. So if you feel like you need to talk to me before doing another cycle of IUI, absolutely, I'm there for you. Having said that, most people will do 2 or 3 cycles of IUI before they want to communicate with me again, because it can easily take at least 2 or 3 tries before you're successful, if not more. So that's not an uncommon thing. Sometimes you need to do it more than once in order to get reasonable success rates. And stay positive. Tomorrow's a big day. When performing a natural IUI, do you still use a trigger shot after the patient has discovered her LH surge at home? Does natural use estrogen or progesterone supplements at all? Thanks. Yes, so natural IUI, you should use a trigger shot, because we just reviewed a study from our friends at Hamilton, Ontario, where they showed that even with a natural surge, adding in the trigger shot improved success rates. So we're actually getting very high success rates with our IUI program now, and so we do that. We add the trigger shot in when you've had your natural LH surge. Estrogen you should use if your lining is thin or you're a really thin person. Otherwise, probably not. And progesterone, yes, we use frequently for most of our patients, even when it's a natural surge, because progesterone has lots of benefits. So we do that all the time, but it's up to the patient. Of course, we like leaving you your autonomy. So if you want to do it, we do. We certainly recommend it. Estrogen, not always, but sometimes, for sure, sometimes. And there's a Fact or Fiction. Gosh, when did we do that one? I think that was like winter, wasn't it?
Was it November?
November? I don't remember. Fact or Fiction on YouTube. We have a study looking at ovulation trigger, even when you're doing natural cycles. So I did review that article. It's pretty cool. We've got like a total lack of questions on YouTube and Facebook. So if you guys have some questions, don't hesitate to ask. When is the best time to start aspirin and Inahap? I've been told to start them on transfer day. Probably a couple days before transfer day, like 1 or 2. Others seem to start 3 days after transfer, too late, and others only when they get a positive, way too late. So the problem with all aspirin heparin studies are they never start them on time. That stuff needs to be there when the embryo is implanting in order to allow for the blood flow to occur on an appropriate basis and for the microvascular structures to develop between your uterus and the embryo. So if you're waiting until 2 weeks has gone by, the whole process has already started, including thromboxane and prostacyclin, which are chemicals that are set up that can actually then lead to complications with the placenta, preeclampsia, stuff like that way later down the line. So you need your aspirin and your heparin before you even ovulate or before the embryo is implanted in a transfer situation. So we always recommend a few days before transfer for sure. Hi, Nikki. Nikki says, this doctor is so amazing. Dr. Victory and his amazing team is the reason I have my dream family. Love you. You're a sweetheart. Thank you, Nick. Okay. Thank you so much. I'd like that information. I will DM you for info. Oh, no problem. I'm happy to help you out. Whoa. Does EndoScratch help implantation after a previous failed cycle? Okay, so endometrial scratching is probably, if not the most controversial part of IVF, it is one of the most controversial. So about a year ago, we presented a study on this, and I brought this up a number of times, where it showed that it was beneficial or it wasn't beneficial. I can't even remember anymore. And then a week later, like exactly a week later, they published a new study which showed the opposite. So it's back and forth constantly on endometrial scratching. The truth is no one's ever really done the right study to figure it out. So at this point in time, we do use it for failures. I don't use it routinely for people. The concept behind it is that the scratch in the uterus makes your endometrium stickier, molecularly stickier, and so that helps the embryo attach. Whether or not that's true, I don't know, but it certainly is not harmful aside from the fact that it's painful. You can introduce infection, but hopefully they're doing it under reasonably sterile techniques. So it should be okay from that aspect. It should always be done in the month prior to your actual cycle, so make sure that's the correct approach. Nikki is saying, love, love, love you. I love you right back, Nikki. You're a sweetheart. Is maca root helpful both male and female infertility? I've only ever seen one study on maca root. It was not a well-done study. It did suggest some benefit. It is definitely not a cure like people claim it is. Yes, it can be helpful, but no, it's not going to take someone with bad infertility or terrible endo and suddenly get them pregnant. So it's kind of a nice adjunct, but it's not treatment for infertility. Okay, we're winding down. Any other questions? At 14 days post 5-day transfer. So by the way, if you guys see something that says a number and then DP and then another number and then DT, it's days post the number of days of the embryo transfer. So 14 DP 5 DT is 14 days post 5-day transfer, like a day 5 transfer. My progesterone was 176, but dropped to 89 2 days later. My HCG doubles. Should I be worried about my progesterone? No, I would actually argue that your progesterone was way too high, and it's now normal. So don't worry about it at all. You're fine. We do monitor progesterone levels, but not 14 days later, because keep in mind, if it was a fresh transfer, all of those eggs that they just retrieved are all producing a ton of progesterone. So that level will go down as the corpus lutei start to retract. What's the difference between Menopur and low-dose Ovidrel? Why would anyone use low-dose Ovidrel instead of Menopur? Okay, so Menopur is FSH, which is intentionally contaminated with HCG, although the company won't admit that. Sorry, my friends at Ferring, I love you guys. But it is contaminated with HCG. It's an awesome product. We use it in almost all our cases. So I love Menopur, don't get me wrong. Great product. Ovidrel is like HCG. So it's not anything like, well, I shouldn't say it's not anything. It's very different from just straight FSH that has HCG in it. This is pure HCG. There are some studies from Italy, actually, from years and years and years ago. I was actually a fellow, I think, when they came out, which showed that for women with PCO, if you wanted to not produce too many follicles, reduce the risk of hyperstimulation, you could give them small doses of HCG after their follicles reached about 12 to 14 millimeters, and only the big follicles would continue to grow and the small ones would die off. That's why people use low-dose HCG therapy. It's from that protocol. I think it was Marco Filicori that published that study. This is going back like 17, 18 years now. 15 to 16 years ago. So that's a reasonable approach. I don't use it because these days we don't worry about hyperstim as much because we use Lupron triggers and very, very few people hyperstim where they need to be in the hospital. If I was on Macrobid once per day for a previous pregnancy due to recurrent infections from interstitial cystitis and a pocket in the bladder not emptying fully, which creates bacteria, should I do this again on the next pregnancy? Yeah, you should. Once you're pregnant, you should go back on Macrobid. That's perfectly reasonable. Or Amoxil, it's probably a little bit safer, but yeah, you should. If you used it before and it worked, do it again for sure. Good question. That was an interesting one. How much folic acid do I recommend? We recommend the high dose, so the 5 milligrams. Thank you so much for answering my question. I can't wait to bug you more about this at my next appointment. No one's bugging me. I love the questions. Keeps me honest. I have done 3 failed IUIs at my current clinic. Oh, I'm sorry, but I feel like it's not the right fit. If I go to another clinic, would they be willing to try IUI again for me? I don't know. It depends on which clinic you're going to. We certainly would, depending on what they did for you before and whether or not it made sense or not. The fit of the clinic is probably not as important with IUI as it would be for IVF. IUI is pretty uncomplicated unless they're messing up something significant. The rates are pretty much the same almost everywhere you go. So it doesn't make a big difference. I was told after 3 failed IUIs, I probably won't have a good chance with it anymore. However, I feel like my clinic uses cookie cutter procedures. So yeah, I mean, if they're doing cookie cutter for you, definitely seek out another clinic. There are places that don't do it the right way. Years ago, there was a study out of London, Ontario, where I did my residency, which showed that your IUI success decreased after your 6th try. It actually started to decrease after 4th, but it became significant after 6th. So we don't do the same thing past 3, maximum 4 tries for that reason, but you can go up to 6 and still have reasonable success rates. Here's a great question. I'm going to post this one up. Hi there, is breastfeeding okay while doing an IVF cycle? So I won't read the rest of the question. No, it is not okay to do breastfeeding while you're going through an IVF cycle. Your prolactin levels are sky high. It messes with your estrogen. It messes with everything else. It won't let your follicles develop properly. So you cannot breastfeed and go through an IVF cycle and expect the same success rates. It will drastically alter your hormones. So do not try that, please. It's a waste of money. Are all women who are pregnant through IVF considered high risk? No. In fact, technically, IVF pregnancies that are singletons are not high risk. However, if the physician that's taking care of you practices fertility, we kind of treat you guys as high risk. So I'm always really cautious with my patients because I actually take care of my obstetrical patients once we've gotten them pregnant. You're welcome for answering your questions, MZ. For that patient you mentioned earlier that had the TSH issue, what dose of estrogen are you using? We're going to aim for none because she's quite concerned that her estrogen levels very significantly mess up her cycles. So we're actually going to do it natural. And that's completely reasonable to do. What is my opinion on fetal Dopplers? Is there a safe time to use them? Oh God, do not use fetal Dopplers at home. I just told someone that today. Don't use them at home. You'll go absolutely mental. There is no reason to use a fetal Doppler at home. If you're worried, go see your doctor. You're just going to drive yourself crazy looking for it. MZ, I'm on 6 milligrams a day. Wow. And my TSH rose to 3.6, transfer next week. Get on some more thyroid medication, and that's a lot of estrogen, but a lot of centers use that, so that's reasonable. Okay, folks, it's 8:59. I got 53 seconds left, so many thanks to Tarek Ibrahim from Ibrahim Strategies Group. Love Tarek. He's become one of my best buddies here all the time to set all this up for you guys, so big shout out to Tarek. All my crew and staff here, amazing people who run this place, are amazing, insanely cool. Lab director, Dr. Khosravi, who is an amazing lady. I'm very honored and proud to work with her. And all my colleagues and friends that make this all possible. Thanks to the physicians out there that do all your great work. I saw one or two names pop up tonight, so thank you for joining us. I feel honored to be seen by you guys, and feel the same towards you. So hopefully you all have a good week. We'll see you again next week. Send us some ideas for topics. I'm going to count on you guys to do that this week. Next week's topic, up to you. We'll throw up like a vote and see what people want, and go from there. Take care, guys. Have a great night.